بسم الله الرحمن الرحيم. متحدثكم اليوم الاستاذ الدكتور عبد الفتاح حنو، استاذ تروبيكال ميديسين كليه الطب جامعه الاسكندريه. Our subject today about schistosomiasis. As regarding the background of schistosomiasis, human schistosomiasis or bilharzia is a parasitic disease caused by trematode flocks of the genus Schistosoma, often known as a bilharzia. الفضل بالنسبه للبلهارزيا اللي اكتشافه عباره عن عالم انجليزي اسمه تيودور بلهارز في 1851 described the cause of the urinary schistosomiasis، والحدث ده كان موجود في كليه الطب القصر العيني. Also في اللي كمل الدوره الفيرست دكتور who described the entire disease cycle اللي هو دي سيلفيا 1908. ما تنساش ان بردك ان كان في الورق بتاع الفراعنه زمان لقوا بردك حاجات تدل على وجود البلهارسيا ايام الفراعنه، وكان بالذات during the maturity في النهايه بيبتدي ان الشاب اللي هو البلغ بقى بيبتدي يحصل تيرمينال هيماتوريا ويسموه حاجه اسمها دريبنج بينس. ده يبقى اذا القصه بتاعت البلهارسيا از عموم. ده تيودور بلهارس اللي هو described the cause of the urinary schistosomiasis. طيب as regards the schisto, we have 5 species of schistosomiasis: Hematobium, Mansoni, Japonicum intercalatum, and the Makongi. Hematobium and the Mansoni both occurred in Africa and the Middle East, whereas Mansoni is present in the Americas. Japonicum is localized to Asia, primarily in the Philippines and China. We'll speak about the different clinical syndromes of the schistosomiasis, those which affecting the urogenital system, what we call the schistosoma hematobium, and the others which are affecting the intestinal, which is the schistosoma mansoni, Japonicum intercalatum, and the Makongi. Our concern today with the schistosoma hematobium as regard affecting the Egyptian people in the Upper Egypt, as well as schistosoma mansoni, which are present along the Nile Valley, starting from Giza down to the Rashid and Edko, where there is schistosoma mansoni. We'll speak about the different clinical syndromes of the schistosomiasis, what we call the acute attack. When any person comes in contact with water and gets infected by the Cercarium, it will take about from 8 to 12 weeks to start the acute manifestation of the disease. If there is previous exposure during childhood, the attack it will be mild. If the first time the attack, it will be so severe and leading to a syndrome described in the Far East and Japan, what we call the Katayama fever. What about the clinical picture of schistosomiasis? Acute schistosomiasis is characterized by fever, chills, weakness, weight loss, headache, anorexia, nausea, diarrhea, dry cough, as well as hepatosplenomegaly and the marked eosinophilia. Why? Because there is a migration of the schistosomia in our body and stimulating the immune system with the production of a lot of eosinophils, as well as enlargement of the lymph nodes and the hepatosplenomegaly. Why? Because the spleen, it is considered one of the reticuloendothelial system, and these are the characteristics of the acute schistosomiasis. If the person for the first time to exposed to the infection, particularly foreigner coming to Egypt, he may return to his country with a fever and what we call the Katayama fever. What we mean by Katayama fever? It is an early after oviposition, after the establishment and the maturation of the worm and the inhabiting and in the portal circulation, the female couples with the males and starts to fertilization and the oviposition. Especially after Japonicum infection, because this syndrome described firstly with the Japonicum infection, patients suffer from acute schistosomiasis, which is the serum sickness-like syndrome. It is characterized by fever, rigors, sweating, myalgia, headache, and usually there is urticaria rash, generalized lymphadenopathy, hepatosplenomegaly, and eosinophilia. So, when we are facing with any foreigner persons coming in contact with an endemic country with schistosomiasis and returning to this country, we must search for schistosomiasis by this clinical manifestation, because it is so easy to diagnose and the treatment. What are the treatment? If the diagnosis is established, we can prescribe for the patient the most recent drug, which is the praziquantel, as will be described later on. This is a very potent in schistosomiasis. The others, which is the xaminoquine, it is used only for schistosoma mansoni. If we are facing with the manifestations of allergy, like that is the itching and fever and rigors, and it is considered as the serum-like sickness, we can prescribe with this schistosomicidal steroid. Steroids act synergistically with schistosomicidal in the treatment of Katama syndrome. We give the anti-schistosomal as well as the steroid in the dose as we all know, and we did for the patient the gradual withdrawal every week until the third week to finish the treatment of corticosteroid. This, what about the acute schistosomiasis? What about the chronic schistosomiasis? We have two main syndromes, those which are affecting the urogenital system as regarding the schistosoma hematobium infection, what we call the urogenital schistosomiasis. And we are faced sometimes with the cardiopulmonary schistosomiasis as well as ectopic schistosomiasis. This is as regarding the hematology, as regarding the schistosoma hematobium. While in the Mansoni, we have what we call the intestinal as well as hepatosplenic, and we will speak later about these syndromes. What about the urogenital schistosomiasis? When any person is infected with schistosoma hematobium, as we all know that and described in the lectures, is the final habitat. It will be in the urinary bladder and is the prostate plexus of veins. The veins surrounding the urinary bladder and the prostate. During the passage of the ova from the blood vessel to the mucosa of the urinary bladder, it will induce inflammatory reactions. And these inflammatory reactions, it will be reflected on the different clinical stages of the disease. If we have heavy infestations and the multiple eggs are present in the urinary bladder, the overlying mucosa may undergo sloughing and necrosis, leading to the ova exposed. The ova, it will be calcified and leading to what we call sandy patch. They are related to heavy calcified eggs with atrophic mucosal covering. Imagine that is the urinary bladder. This urinary bladder, there is an oviposition in the mucosa, and the eggs try to pass from this mucosa. It will lead an ulcers. The others, heavy deposition of the ova, it will be calcified with time and depriving the overlying mucosa from the blood. So there is a sloughing and the necrosis, and the exposed part of the submucosal is the multiple calcified ova, giving a clinical picture of what we call the sandy patch. Or when the ova pass from the mucosa to the lumen to pass outside during maturation, it may leave ulcers, leading to what we call the vesical ulcer. Sometimes the response of our body to these ova, which are present in the mucosa, it will lead to the hypertrophy of the overlying mucosa and leading to what we call the polyps. The polyp may be sessile, may be pedunculated, may be simple polyp, may be branched polyp, may be cauliflower. This is either polypoidal lesion. It is a sort of inflammation, and the body response to the bilharzal granuloma have more than one bilharzal granuloma with each other, leading to what we call the polypoidal lesion. Sometimes there is an invagination or involvement of the submucosal layer by multiple layers from the superficial of the urinary bladder, leading to what we call the cystitis glandularis. When there is heavy affection of the bladder it will become what we call the contracted bladder. What we mean that the urinary bladder have the trabeculation. When it is an empty without urine, it is collapsed. When there is urine, it will be distended up to 500 millimeter of letter. Urine can be stored in the urinary bladder. If there is heavy infestations by the schistosoma inflammations and the granuloma, it may be impede this movement, leading to what we call the contracted bladder. That is to say, the capacity of the bladder to contain urine, it will be decreased, and disease will be manifested later on the patient by what we call the frequency. And the ureter to open in the trigon of the urinary bladder, it may be affected, the lower third of the ureter. This is the most vulnerable part of the urinary bladder or urinary systems. It may lead to the hydroureter and the recurrent strictures and the inflammation and the hydronephrosis. These different manifestations or affection of the urinary bladder, it will be reflected on the patient by what we call frequency. The repetition of urination with a small amount, what we call the increased urinary frequency. And superadded bacterial infection, it will lead to what we call the burning maturation. And one of the hallmark of the urinary schistosomiasis, which is described in the old ancient people as the terminal hematuria. Why terminal hematuria? Because of the bladder containing urine, the urine will pass easily. At the end of the urination, there is a remnant of the bladder in need for the contraction of the trachea. The movement of the muscles here, it will lead to the injury by the ova, which is the schistosoma hematobium ova, which is the terminal spine, leading to what we call the injury of the mucosa, and final, at the end of urination, there is some bleeding, what we call the terminal hematuria. So clinically, maybe if you are facing by the frequency at burning micturition and the terminal hematuria, as well as the suprapubic discomfort, especially noted with schistosoma hematobium. This is a clinical presentation, and these are representing the different clinical pictures or the different pathological changes which are occurring in the urinary bladder as regards these sandy patches, even the sessile polyp, and the thickening and the fibrosis of the wall of the urinary bladder, leading to what we call the contracted bladder. What about the complication? If this patient suffering from urinary schistosomiasis does not treat it, there is an infection of the ureter leading to what we call the schistosomal obstructive uropathy, leading to the hydroureter and hydronephrosis. With time and the stagnation of the urine, it will lead to secondary bacterial infection, urinary tract bacterial infection, and sometimes these acting as the predisposing factors for the urinary stones and the chronic irritation, with the end result of the cancer bladder, and maybe end with the impairment of the kidney function and finally renal failure. So we are in need for early diagnosis and to give the treatment, proper treatment, in order to avoid these complications which can occur. And there is a very good relationship between urinary schistosomiasis and the cancer bladder. And disease is most commonly in our country secondary to the urinary schistosomiasis. We have different histological types, and we have a specific type for urinary schistosomiasis cancer bladder, what we call the squamous cell carcinoma, SCC, squamous cell carcinoma. The major histological cell types of the bladder cancer associated with schistosomiasis of the urinary tract is the squamous cell carcinoma. Why? Because there is a chronic inflammation and irritation, stagnation with the production of the nitrosamine. This nitrosamine considered as the precancerous. So we have a specific type for cancer bladder, which is SCC, squamous cell carcinoma. In the opposite, or in the contrary, in the industrialized countries such as North America and Europe, the bladder cancer occur mainly at the transitional cell carcinoma. So cancer related to the urinary bladder, which is the squamous cancer in the urinary bladder, or urinary carcinoma related to schistosomiasis, is squamous cell carcinoma, while in other non-schistosomal, which is the transitional cell carcinoma. Of course, we have other histological cell types, but it is very rare to occur. And here we are having a special interest with the cancer of the urinary bladder, which is the squamous cell carcinoma. Why? Why those patients suffering from urinary schistosomiasis more susceptible for cancer bladder? Because schistosoma induce the chronic inflammation and the irritation of the urinary bladder. The inflammatory cells, the macrophage or neutrophils, it is considered as an important source of endogenous oxygen radicals, which are also implicated in the formation of the carcinogen and nitrosamine. So we have an added factor like that of bacteria, Staphylococcus aureus, and so, which are acting and reducing the amines into mediating nitralization reactions, leading to secondary amines and nitrate under condition of physiological pH normally encountered in the urinary bladder, and hence consequently induction of the pre-neoplastic initiation event in schistosomal infected subject. So we have a good relationship between urinary schistosomiasis and the cancer bladder, and the different mechanisms which are involved through the carcinogen and nitrosamine, or through the bacterium, which can lead to the pre-neoplastic events and the initiation of the cancer bladder. The second, the clinical syndromes which are known to occur in urinary schistosomiasis is the affection of the heart and lung, what we call cor pulmonale. Cor coming from the cardio, pulmonale coming from the lung. What is the relationship between schistosomiasis and the cor pulmonale? As we all know, that is the urinary bladder and the prostatic plexus of veins are supplied by veins which are drained in the internal iliac vein. The internal iliac vein union with the external, leading to the formation of the common iliac vein, which are going to the heart through the inferior vena cava, from the heart to the right side of the heart through the pulmonary artery to the lung, and then the other part of the circulation. So if there is ova, this ova carried from the urinary bladder through the anterior iliac vein, it can reach to the lung through the pulmonary artery and inducing inflammation and the granuloma. Of course, this granuloma, it will be reflected in the hemodynamics of the right side of the heart, which it will be later on leading to the hypertrophy and maybe heart failure, what we call cor pulmonale, affection of the heart, as well as affection of the lung. Secondly, schistosomiasis, which is the vascular type of cor pulmonale. Let us go to explain this more and more. During the migrations of the schistosomia in our body, and the larva going to the lung, may lead to what we call the larval pneumonitis. This condition is due to the allergic state produced by schistosomia in the early phase. So the lung can be affected by a pneumonia, like what we call the larval pneumonitis. The other part of the cardiopulmonary schistosomiasis is the schistosomal cor pulmonale. This is explained by the fact that the venous plexus of the urinary system communicate freely with the inferior vena cava. عشان كده الهيماتوبيوم eggs will be filled in the lung, going to be filtered. The filtration, because the size of the ova it is large, it will be trapped in the lateral parts of the blood vessel and the lung, which leading to the formation and inflammation of these blood vessels and leading to the cor pulmonale. So, schistosoma hematobium ova may be carried to the right cardiac chamber from the perivesical venous plexus through the inferior vena cava. This is most commonly to occur in hematobium. What about Manzoni, which are present around the rectum and the ileal canal? And this part of the circulation, it is related to the portal circulation. If the Manzoni can go, if the Manzoni can go to the right side of the heart, yes, through the collaterals between the portal aspect and systemic aspect, and in such cases, patients suffering from the urinary schistosomiasis, it is easy to produce cor pulmonale, but patient with intestinal schistosomiasis, in order to produce cor pulmonale, it is a must for the formation of the portosystemic shunt in order to reach this Manzoni to the lung and producing pathological changes which lead to the cor pulmonale. The manifestation of the disease and the affection of the lateral part of the blood vessel in the lung, it will lead to what we call the obstructive pulmonary hypertension. This is the morbid physiological expression of these lesions. What about the clinical picture? Patient suffering from schistosomiasis, whatever hematobium or Manzoni, coming to you with the shortness of breath and sometimes easy fatigability, and we discovered that the patient suffering from urinary or intestinal. By the ultrasound, we can prove that is this patient suffering from schistosomiasis. Even the chest X-ray can explain, and the echocardiography can diagnose this easy. What about the signs and symptoms? Which the patient suffering. Most of cases of the cardiopulmonary schistosomiasis or the bilharzial cor pulmonale are asymptomatic or may be associated with shortness of breath, sometimes dyspnea. Cyanosis may occur if the peribronchial arteriovenous shunts are opened. During the clinical examination, there is a typical sign of the pulmonary artery dilatation and the hypertension and the pulmonary ileugemia, as well as this is the pulmonary aspect. Why? What about the cardiac aspect? The right ventricular failure with severe tricuspid incompetence are terminal event. The incidence of cor pulmonale in patients with the urinary schistosomiasis is much lower compared to the reported in those with hepatosplenic schistosomiasis. Let us to stop here and explain. So, in cases of the urinary schistosomiasis, it is easy for the schistosoma hematobium to go to the lung and producing these manifestations of cor pulmonale. But in Manzoni, it is so difficult. It must be there is opening of the shunt between the portal aspect and the systemic aspect in order to reach to the lung and the affection of the terminal blood vessel, leading to the inflammation and the granuloma formation and the formation of what we call the end arteritis obliterans and the end arteritis proliferans. This is as regards the acceptability, the access. What about the antigenicity? When the Manzoni are present in this situation in the lung, it is more antigenic and they can produce more pathology rather than the hematobium. This is which explained and present in the literature why the Manzoni suffer, patients with schistosoma Manzoni can suffer from severe form of cor pulmonale because it is, when it is present in the lung, it is more antigenic. This picture representing the difference between the normal heart and the right side of the heart. There is hypertrophy and the thickening of the right ventricle, and there is dilatation of the pulmonary artery. X-ray, there is an enlargement of the pulmonary area in the lung and right ventricular apex, and it is supposed that there is a peripheral leukemia of the lung, and this is a clinical picture of the cor pulmonale. The second X-ray, the same, right-sided heart, right ventricular, the apex is right ventricular. There is enlargement in the shadow of the pulmonary artery, as well as peripheral leukemia, and this is considered the X-ray finding of the cor pulmonale. So the patient suffering from schistosoma hematobium may be affected by the urogenital system, affected the cardiopulmonary system, and sometimes there is an ectopic schistosomiasis. Doctors, schistosoma can affecting area other than the lung and the heart and the urinary system and the gastrointestinal tract. Yes, what we call ectopic schistosomiasis. When the schistosoma present an abnormal site other than the urinary system and the gastrointestinal tract and the liver, it is considered as the ectopic, like that of the schistosoma lesion occupying the brain, the spinal cord, the skin, the eye, body, and other organs. So through the vascular connections can go to these areas. The most common presentation is the neuroschistosomiasis. Actually, we didn't diagnose such a case, but our colleagues in the department of the neurosurgery, when are facing with a granuloma in the brain, and send these biopsy to the clinical pathology for pathology for examination, they discover that this is a bilharzia granuloma. It is rare, but it is present, and it is put in the differential diagnosis of intracerebral lesions. Ectopic ova gain access to the central nervous system through the anastomosis between the lumbar veins. This lumbar vein, it is a tributary of the inferior vena cava, وطالما بنقول inferior vena cava يبقى ده عبارة عن systemic aspect. والinternal vertebral venous plexus, they may deposits and provoke granuloma formation like in the adjacent spinal cord or travel kefaldi during coughing and straining and the emptying into the brain tissue. يبقى from the gastrointestinal tract through the lumbar veins can go to the central nervous system where they are settled in the brain and producing granuloma. Clinically, the patient, it is a most severe clinical syndrome associated with schistosoma infection, signs and symptoms of increased intracranial pressure. There is maybe myelopathy, radiculopathy, maybe the lesion involve an irreversible glial scar if it is untreated. The complications of cerebral disease include the encephalopathy, headache, visual impairment, delirium, seizures, motor deficit, as increased intracranial tension and the brain lesion. The second issue is the affection of the kidney. When we are prescribing the urinary schistosomiasis, there is affection of the urogenital system, hydroureter, hydronephrosis. This is a mechanical due to the presence of the granuloma itself. What the other aspect of the glomerulonephritis? It is an immune-mediated disease. During the migration and the stimulation of the immune system and the antigen, it is schistosoma hematobium, the antibody from our body, it may be deposited in the kidney, leading to what we call the glomerulonephritis. But this manifestation, it is considered an immunological reaction, not direct affection by the granuloma. Proliferative glomerulonephritis with schistosomal antigen deposits have been identified as the manifestation of early hematobium. The patient, it will suffer from what? العيان اللي بيجي له glomerulonephritis عنده بروتينوريا، هيماتوريا، هايبرتنشن، والحكايه ديت بنقدر نشخصها بالرينال بايوبسي، ولما العيان بياخد علاج العيان بيخف كويس وبيحصل له كومبليت ريكفري. ليه؟ لان ده عباره عن immunological reaction. We don't forget that is the genital area it may be affected, particularly in females and males, with all area can be affected, what we call the genital schistosomiasis. Even the skin may be involved by a nodule, and the biopsy illustrating this is nodule, it is secondary to the granuloma. Even the eye, also the peritoneum can be involved by the bilharzial granuloma. This is the end of the urinary schistosomiasis. This is the end of my lecture, I mean that. What about the schistosoma mansoni affecting the gastrointestinal tract and intestinal, which is the most common here, and the Nile Delta? We have two clinical pictures. The first one is the intestinal schistosomiasis. The second is the hepatosplenic schistosomiasis. كل القصه دي كلها زي ما اتقال قبل كده لحضراتكم ان ده له علاقه بالعدوى نتيجه لوجود الكونتاكت مع الووتر، والكرتون ده بيفسر لنا هذه القصه اللي بيكون عندها العيان جاله الانتستينال او جاله هيباتوسبلينيك. يبقى اذا العيانين بتوع الانتستينال دول في عندنا في مصر نتيجه للمنسوني، في الفار ايست نتيجه لجابونيكام. القصه كلها ان الاوفا when it is present in our body it is considered as the foreign body. So our body, it will define and it will surround this ova by what we call the granuloma. This granuloma, it is a beneficial. Why? It will prevent the escape of the antigenic substances from the eggs, which is the highly allergic and antigenic, and they can induce shock for the patient by this inflammatory granuloma. But we have the side effect of this granuloma, which can lead to different pathological changes which are occurring in the gastrointestinal tract, or even when reaching the liver, it will lead to the periportal fibrosis. So the main affection of the gastrointestinal and the hepatosplenic is the granuloma, with the formation of the pseudopolyp and the macroulcerations and even fistulization and the strictures. And sometimes it is not common to faced by the bilharzial mass, and maybe it is not always a cancer of the gastrointestinal tract. The mucous membrane shows focal inflammatory reactions with the pinpoint hemorrhage during the passage of the ova from the rectum and the anal canal. This passage, it will lead to the inflammation and the granuloma formation, and maybe it's the ulcers and the microscopic ulcers. I mean that this is associated with the lower abdominal pain and the tenesmus, as it reflected on the clinical picture of the patient, with the repetition of infection and the defense of our body by different granuloma. The granulomas may be coalesced with each other and forming what we call polyp. As mentioned in the urinary system, the polyp may be sessile, pedunculated, simple, branched, or may reaching to a large size, what we call the cauliflower. Even in children suffering from the recurrent infection or affecting the rectum and the anal canal may suffer from the rectal prolapse, and may be affection of the different layers of the colon, starting from the mucosa, submucosa, the muscularis mucosa, even the serosa, with the infiltration by different granulomas and the thickening of the colon, leading to what we call the bilharzial mass. And this is most commonly to present in the left side of the colon. These different pathological changes, it will be reflected on the patient by what? Number one, the patient may be asymptomatic. Why? Why patient may be symptomatic and the other asymptomatic? According to the intensity of infection and the number of exposure. If the patient exposed gradually to the infection, as happened here in our country, during the mother going to the outside her home to wash his clothes and things, and taking his children to the river, these children, it may be exposed to gradual infection. If the patient exposed for the first time, it will be drastic, severe reaction. So when the patient is exposed to the infection gradually, he he does not suffer from anything except very mild form, because we have what we call tolerance for the infection, leading to asymptomatic affection. Or during the acute phase of schistosomiasis and the passage of the ova and the induction of inflammation, maybe there is a bilharzial dysentery. Also, there is a gradual onset of patient suffering from dysentery. By definition, this is easy pain during. It is not pain during defecation. It is a collection of symptoms suffering the patient from it, like that the lower abdominal pain, cramp, straining as a stool, what we call the tenesmus, and the frequent passage of watery diarrhea of the stool, and the stool may be containing blood and the mucus. This is a dysentery. So the word dysentery, it is a collections of signs and symptoms present on the patient. What we mean by dysentery. Or the patient may be suffering from intermittent diarrhea, crampy abdominal pain with the frequency of symptoms often related to the intestinal infection. All of these symptoms, the abdominal pain and the dysentery and so may be lead to fatigue of the patient. But this is the clinical presentation of the patient suffering from acute intestinal schistosomiasis. Later on, due to the formation of ulcers and polyps, the patient may be losing protein, leading to what we call protein losing enteropathy. It may occur secondary to ulcers, facial and strictures. When the patient suffering from chronic infection with loss of appetite and the recurrent abdominal pain and the dysentery may be lead to the anemia. This is one of the manifestation of the chronic illness and schistosomiasis. Even severe long-standing polyps may be lead to the intestinal obstruction. This intestinal obstruction, actually, it may be partial obstruction. It is not complete obstruction, but most commonly partial obstruction, very rare complete. And this is the clinical presentation. When we are facing with the case of intestinal schistosomiasis, we must put in our mind the differential diagnosis of the intestinal schistosomiasis. Dysentery we have a multiple causes of dysentery. Other condition which can cause bowel lesions that should be differentiated from schistosomiasis, like that our concern in the tropical medicine department, amoebic dysentery, bacillary dysentery, maybe Giardia, maybe the inflammatory condition of the gastrointestinal tract, what we call the inflammatory bowel disease, ulcerative colitis, and the Crohn's, maybe TB of the gastrointestinal tract, maybe lymphoma, maybe adenocarcinoma. All of these are put into consideration during the differential diagnosis of the gastrointestinal schistosomiasis. It is so easy to diagnose when we are looking for the different pathological changes which are occurring in the mucosa by what we call the sigmoidoscopy. It is a rigid apparatus or flexible sigmoidoscopy to illustrate the lower part of the gastrointestinal tract starting from the anal canal, the rectum, the sigmoid, even part of the descending colon. And also we can use the colonoscopy for the diagnosis of different polyps, acid polyp, or the X-ray, what we call the barium enema, injecting barium sulfate into the rectum and the anal canal, and the barium will pass to the whole colon, and the area which are present here like that of the multiple filling defects, and this denoting or reflecting what we call intestinal polyposis. This can be easily diagnosed by sigmoidoscopy or colonoscopy or even the barium enema. And this specimen representing the different changes which are occurring in the mucosa. If you imagine that this is the mucosa, and we have here the polyps, we have different types of polyps, side polyp, simple branched polyps. Even the polyps may be large, like that of the cauliflower mass. So this is a common presentation for a case of the intestinal polyposis, which now it is considered as the few and rare, and it is must put in our mind because we have the prevalence of schistosomiasis nowadays decreasing. These other specimens representing the different shapes and forms of the intestinal polyps which are present in this specimen, and this can be seen on the patient suffering from the gastrointestinal schistosomiasis. If we are taking biopsy and proves that this patient suffering from schistosomiasis, we can prescribe for him different anti-schistosomal drugs and correcting the underlying factors, and this patient can be recovered and the condition or the pathological changes can be stopped at that stage. The other part of the gastrointestinal schistosomiasis or schistosoma mansoni is the hepatosplenic schistosomiasis. When the ova are present in the portal area, it is about half of this ova, it will go outside the body, and the other it will be remaining in the veins surrounding the rectum and the anal canal. What are the fate of this ova? This ova can be carried with the blood flow to the liver, and there the liver it will be going to the portal vein, the right and left portal veins, and finally it will be settled in the portal area. As we all know that the portal area containing 4 structures, 2 going to the liver and 2 outside the liver. 2 which are structures which are going to the liver is the branch of the portal vein and the branch of the hepatic artery. And the 2 going outside the liver, which is the bile canal coli and the lymphatics. And the ova, when it is present through the portal tributaries to the through the portal vein tributaries to the portal area, the size of the ova is large, so it can cross to the hepatocytes, to the sinusoids, and it will be trapped in this portal area. We all agree that the ova, it is considered as the foreign body. So our protective mechanisms from our body, it will be stimulated, the innate system, and the cellular immune system. So this ova, it will be surrounded by granuloma. These granuloma which are present in the portal area, it will induce hemodynamic changes in this portal area. And so the prescription of the schistosomal hepatic fibrosis or the periportal fibrosis, due to the multiplicity of the granuloma in the portal area, or leading to the prescription of what we call the periportal fibrosis. So the main pathological issue in patients suffering from hepatic schistosomiasis or hepatosplenic schistosomiasis is the presence of the granuloma in the liver. The most common granulomas are due to the ova, but maybe the adult worm going when it is taking antibilharzial and loses its suckers, attachment to the endothelium of the blood vessel. It can go with the blood flow to the portal area and induce inflammation and induce pathological changes. Let us see what happened for the patient suffering from the hepatosplenic schistosomiasis. Number 1, the granuloma formation due to the egg deposition in the portal tract, as mentioned now. The site of the granuloma, it is present in the periportal area, which is considered as the pre-sinusoidal. So we are putting a differential diagnosis for portal hypertension في pre-sinusoidal cause, sinusoidal, post-sinusoidal. لما نقول pre-sinusoidal, the most common example here is the bilharzia granuloma. Why? Because the ova are present in the portal tract and inducing fibrosis and scar formation, which is affecting the portal vein diameter and sometimes opening the artery with the vein, leading to the arterialization of the branches of the portal vein and the increased pressure in the portal vein, and so on and so on. This is a pre-sinusoidal periportal fibrosis due to the healing of the granuloma. What are the consequences of this granuloma which are present in the portal area? There is an obstruction for the flow. As we all know that the pressure, it is equal flow in the resistance. When there is the flow obstructed by the presence of the obstruction by the granuloma, so it will lead to the increase or resistance to the flow. As well as the area which is inflamed and there is hyperemia, there is an increase in the flow. The end result of the increased resistance to the blood coming from the portal vein by the presence of the granuloma and the inflammation which is induced by the granuloma, it will lead to the increased field pressure in the portal area, which is the main hallmark or the clinical presentation of patients suffering from periportal fibrosis is the portal hypertension, because the schistosomal here, it is affecting the mesenchyma leading to the portal hypertension. On the contrary, على عكس يا اولاد بقى العيانين عندهم فيروس هيباتيتس ما لهمش دعوه بالبورتال اريا خالص، ده كل القصه موجوده في الهيباتوسايتس والنيكروزيس والسيروزيس وبيعمل بورتال هايبرتنشن نتيجه لوجود الافكشن اوف ذا هيباتوسايتس. لكن في العام بتاع البلهارسيا القصه كلها موجوده فين؟ في البورتال اريا. عشان كده بنقول البلهارسيا اتيز بري ساينوسويدال بورتال هايبرتنشن نتيجه لوجود الجرانيولوم. طب what are the consequences of this portal hypertension؟ نتيجه للانكريز للريزيستنس للفلو ونتيجه لوجود الثيكنينج والفايبروزيس والانجيوماتويد فورميشن في البورتال اريا والارتريلايزيشن اوف ذا بورتال فين. All of these sequences it will be reflected on the spleen, leading to the splenomegaly. In the portal vein, portal hypertension, opening of the collaterals between the portal and systemic shunt may be help in the development of ascites, may be lead to the rupture of this collateral and esophageal varices. And so these are the consequences of the granuloma which are present in the portal area with the portal hypertension. So the clinically or changes the portal hypertension, splenomegaly, variceal hemorrhages, and the ascites, all of these are as a consequences of the granuloma which are present in the periportal area. And the portosystemic shunt, it will be opened. Why? Because there is an obstruction to the flow. And if there is no opening for the shunt, the area will be congested and the hyperemic and leading to the physiological changes, the fullness and maybe bleeding and so on, like that of the portal vein thrombosis. But in order to overcome and this problem, there is an opening of the shunt between the portal aspect and the systemic aspect. Why? To escape and take the blood from the portal area to the systemic area. This has a disadvantage. What about the disadvantage of this opening of this collateral? Number one, those which are present in the lower end of the gastroesophageal junction or the lower end of the esophagus may be esophageal varices and bleed. Others which are present in the rectum and the anal canal may lead to bires. It will lead to the passage of the substances from the gastrointestinal tract, because the portal vein it is concerning with the absorption of the nutrient and the proteins and the amino acids to the systemic circulation directly without detoxification in the liver and the production of what we call hepatic encephalopathy. يبقى the portosystemic shunt it is a beneficial, but carrying with this is the substances which are detoxified in the liver, leading to the manifestation of what we call increased ammonia and hepatic encephalopathy. This is a classical picture of the case of the periportal fibrosis inside the liver, because the granuloma is here surrounded by the inflammation and leading to the obstruction of the hepatic venules and the production of portal hypertension. And this can be seen easily with an ultrasound of the abdomen showing the enlargement of the central periportal pans with the increased echogenicity suggesting of inflammation of the intense periportal fibrosis due to the affection of the liver. This can be diagnosed by ultrasound. Here representing the problems of the portal hypertension and the opening of the shunt. This is the most important one, which are present in the lower end of the esophagus, the second at the lower end of the rectum and anal canal, the third area between the spleen and the kidney, around the umbilicus caput-medusa, in the pear area of the liver, and the inner scar of previous operation. As mentioned before, the shunt, it is beneficial because it's carrying the blood from the portal area to the systemic circulation in order to avoid the congestion and fullness and the bleeding. But the hazards of this shunt is the complication, as mentioned before, the hematemesis and the hepatic encephalopathy. Clinically, the patient, it may be suffer from what? During the early stage and the presence of the granuloma in the portal area, it will lead to the enlargement of the liver. Here the liver, it would have the smooth surface, a large 2 or 3 finger below the costal margin of the regarding the right lobe. The left lobe, it will be present also in the midline, however 3 or 5 fingers below. The liver is tender due to the presence of the granuloma, and the spleen at that stage, it may be enlarged. Later on, the spleen, it will be enlarged more and more, and the liver, it will be not tender, what we call the hepatosplenomegaly. Early, the first phase or the first clinical presentation or the clinical stage of patients suffering from schistosomiasis is the hepatomegaly. The second is hepatosplenomegaly, and later on, with the increase in the pressure in the portal area, it will be reflected on the spleen, leading to what we call the portal hypertensive splenomegaly or congested splenomegaly. So the spleen, during the early phase of the disease, it will be enlarged due to the reticuloendothelial hyperplasia. Later on, secondary to the portal hypertension. With time and increase in the portal pressure with other causes, it will help in the production of the ascites, the rupture of the varices, it may be hematemesis and the melena, and even the passage of the nitrogenous substance to the brain. Without detoxification in the liver, it will lead to the neuropsychiatric manifestation of the disease, which is known as the hepatic encephalopathy, and later on, the patient may be suffer, particularly even sober added factor on periportal fibrosis, it may be suffer from the hepatocellular failure, all of the manifestation of the hepatocellular failure, and this is the not most common in patients suffering from schistosomiasis, except this patient having a mixed infection with virus hepatitis. From the functional point of view, we can classify the hepatosplenic schistosomiasis in 2 different stages. The first one is the compensated. What do we mean by compensated? It is asymptomatic, and some may complain from dyspepsia, flatulence, dragging pain in the left hypochondrium due to the enlargement of the spleen. This is a compensated. Patient suffering from schistosomiasis, taking treatment, removed from the for infected area, it is known as the arrested form. But if the current continuous infection with enlargement of the liver and the spleen, but the liver is coping with function, it is known as the compensation. And sometimes patients suffering from schistosomiasis, it may lead to the decompensation. So the liver, it is consisting mainly from parenchyma, which is the functioning unit in the hepatocyte, and the mesenchyma. There is the portal vein, hepatic artery, collateral bile canal coli. If there is parenchymal affection, there is hepatocellular failure, like that of virus hepatitis, for example. If there is mesenchymal affection, but there is portal hypertension. If we have both mesenchymal and the parenchymal, what we call the ascites can be produced. So the patient suffering from schistosomiasis may suffer from mesenchymal decompensation with development of portal hypertension. Very rare to suffer from parenchymal decompensation, except this patient associated with them mixed infection by virus hepatitis, and this situation, it is common in our country. In the past, due to the virus C, due to hepatitis virus C, now we have faced with a little case of HCV, but we have cases of HPV. These changes which occurring in the liver and the spleen, occurring the schistosomiasis, may be presenting by hematemesis for the first time. So it is surprise. Yes, patient catching infection during childhood and transfer to the city and acting at the work, the employment in any job. With times there is an increase for portal pressure, portal hypertension, may be coming to the outpatient clinic or emergency unit by hematemesis and the melena, and does not know about his condition, if suffering from liver disease or not. So we have what we call hematemesis or melena, may indicate gastroesophageal varices, bleeding, and the bleeding from the portal area. Or changes in the mental state, what we call encephalopathy for the first time. It is rare but can occur. Increasing abdominal girth when there is development of ascites, abdominal pain and fever, and finally the patient may be suffering from bleeding from the rectum and anal canal, what we call hematochezia. So these are the different clinical presentation of patients suffering from gastrointestinal and hepatosplenic schistosomiasis, secondary to the pathological changes and the changes which can occur. Here there is an increase in the abdominal collateral, secondary to the portal hypertension. The second one is the periumbilical collateral, secondary what we call the caput medusa. This is a prominent collaterals are present secondary to the portal hypertension. These are present in real life. The second most common complication in patients suffering from ascites is the umbilical hernia. And this is, to my mind and my concern, it is very dangerous because this hernia may rupture and leak of the athletic fluid, the patient getting infection and the sudden hypotension and the privation of the blood to the brain, to the kidney, to the liver, maybe multi-organ failure from this hernia. So if we discover this hernia early and the condition of the patient fit for surgery, it is better to operate upon this umbilical hernia in order to avoid the complications which can occur for the patient. You follow me? That's good. Perfect. Also, this is the lateral view نتيجة لوجود العيان عنده ascites وعنده umbilical hernia وبرضك لأن ده one of the most common complication يا شباب نتيجة لوجود الهرنيا. Perfect. This is the another for the rectal varices and the hemorrhoids. And this is the most common, and you will see in the clinical round. Clinical round is the splenomegaly due to the portal hypertension and reticuloendothelial hyperplasia, secondary to the affection of schistosomiasis. And this is the most drastic endoscopic finding of a patient suffering from esophageal varices with different grades and the bleeding from these varices نتيجة لوجود الportal hypertension. So, when patients suffering from hepatosplenic schistosomiasis, if you didn't treat this patient, you must expect that you will suffering from complication. The most is portal hypertension with its consequences and rarely liver cell failure بالذات لو العيان كان معاه بالهرسيا ومعاه فيروسات للكبد، الاثنين دول بيشتغلوا مع بعضهم وممكن يعملوا liver cell failure. طب ايه الحاجات اللي ممكن تيجي مع العيان بتاع البلهارسيا عشان تعمل له المشاكل دي كلها؟ عندنا الاتش اي في. الاتش اي في ده مشكله دلوقتي حاليا. طب هل العيان بتاع البلهارسيا وعنده مشكله في المناعه ممكن يجي له اتش اي في؟ يس، موجوده قدام حضراتكم. The most compelling example might be the effect of schistosomiasis on susceptibility of HIV infection. Among women with female genital schistosomiasis, inflammation of friability and the new vascularization of the genital epithelial tissue يؤدي إلى compromised physical barrier to the exposure of HIV through sexual activity. يبقى العيان بتاع البلهارسيا والست اللي عندها بالهارسيا وعندها مشاكل في الجينيتال اريا ممكن لو في حته انديميك في الاتش اي في يبقى عندها مور سسبتابيلتي للانفكشن بالاتش اي في. طب وات اباوت هيباتيتس فيروسز؟ عندنا الاتش بي في والاتش سي في، والحمد لله نتيجه للجنه القوميه بتاعه الرئيس علاج المليون مواطن، وده حاجه جميله جدا جدا على مستوى العالم كله، على مستوى جمهوريه مصر العربيه، وانجاز علمي فظيع جدا جدا مليون صحه ان احنا الحمد لله اراديجيت هيباتيتس سي فيروس. طب هل وي هاف هيباتيتس بي فيروس؟ يس. في انتر اكشنز بين الاثنين؟ يس. في العيان بتاع الاتش سي في والعيان بتاع الاتش بي في، والعيانين دول بقى لما بياخدوا الليفر بيأثروا على اللي احنا قلنا عليه ايه؟ اللي هو البارينكيمال اسبكت مش الميزنكايمال اسبكت، وده اتشرح بالتفاصيل مع زملائنا في التخصصات المختلفه. هل العيانين بتوع البلهارسيا ممكن يجي لهم بكتيريال انفكشن؟ يس. عندنا سندروم شهير جدا جدا حاجه اسمها كرونيك سالمونيلوزيس. العيان عنده فيفر، عنده تيفويد، وعنده شيستوسومايسيس، بنعتمد على التيفويد بالفيدال والشيستوسومايسيس بالانتيجين او بالستول اكزامينيشن زي ما اتقال لحضراتكم كده في مع زملاتنا في البارازيتولوجي. والعيان عنده برولونجد اندولنت فيفر، في الحاله ديت ده بنطلق عليه كلمه عباره عن كرونيك سالمونيلوز. يبقى اذا العيان ده بيجي له سالمونيلا انفكشن اون توب اوف بالهارسيا، والاثنين بيحصل لهم انتر اكشن. طب ليه؟ لان لو ان السالمونيلا ديت بتعيش على التاجمنت اوف ذا بالهارسيال وور وتخش جوه الانتستينال سيكم، ولما العيان ياخد علاج يخف شويه وبعد كده تيجي عامله فوميتنج والبكتيريا تاكل سيركيوليشن تاني وتبقى موجوده في الدم وتعمل المانيفستيشنز بتاعتها. طب هل هي القصه كلها بس سالمونيلا؟ لا، ده ممكن يحصل تيوبركلوزيس ويحصل ستافيلوكوكال انفكشن وسكشوال ترانسميتد ديزيزز وكلاميديا ومايكوبلازما وترايكوموناس. ليه؟ لان العيان ده عنده كرونيك إلنس، انيميا، وعنده مشكله في الاميون سيستم، فبالتالي سسبتبل للبكتيريا الانفكشنز الموجوده. وده القصه بتاعت الكرونيك سالمونيلوزيس، هاو تو دايجنوز اند هاو تو تريت ذوز بيشنت. ده عباره عن نتيجه لوجود السالمونيلا انفكشن. ودي الكلينيكال بيكتشر بتاعتنا. مهم جدا جدا الفيفر، برولونجد فيفر، شوفوا بتاخد من ايه، من سيفرال ويكس اب تو فيو ييرز، وفي بكتيريميا نتيجه لوجود السبيشيز بتاع السالمونيلا، وكرونيك اكتيف شيستوسومايسيس، ويت اوكير موست كومنلي ان ميل ما بين الايج 10 ل 30 سنه، والبيشنت بيكومبلين من فاتيج وماليز ويت لوس وفيفر وايفن بكتيريميا، ويبقى في توكسيستي وهيباتوسبلينوميجالي، وزي ما قلنا التشخيص بتاعها والتريتمنت بيكونوا عباره انتي شيستوسومال از ويل از انتي سالمونيلا، ميبي تيكن concomitant مع بعضيهم او ورا بعضيهم، فبيجيب فيري جود ريزلت عندنا. هل ممكن يحصل العيانين دول اذر بارازيتيك انفكشنز؟ يس. يعني انفكشن مثلا بالملاريا والليشمانيا وموجود في الاماكن اللي فيها انديميك في الحاجات ديت كلها، وبيحصل لهم انترفيرنس مع بعضهم، يس، وبيبرودسبوز كده. وصلنا للفاينل ستوب للعيانين بتوع الشيستوسومايسيس. هنديهم علاج ولا مش هنديهم علاج؟ وايه فايده العلاج؟ ده اللي احنا بنسميه كيموثيرابي. في فايده للعيان وفي فايده للمجتمع. مهم جدا جدا فايده المجتمع ده عشان تو ستوب the increasing في prevalence of the disease. Benefit to the patient: be relieve the patient symptoms. It is followed by healing of the pathological lesion. Be prevent further damage. يبقى ده البنفيتس بتاعت العيان، او occurrence of complications and preventing further deposition of eggs. Early fibrotic lesions are reversible with early treatment. من فضلكم خلي بالكم هنا ايه، early fibrotic lesions are reversible with early treatment. يعني العيال لو احنا شخصناها بدري وخد علاج هنوقف كل الباثولوجيكال تشينجز اللي احنا شرحناها، ايا كان موجوده في اليوروجينيتال سيستم او موجوده في الجاسترونتستينال تراكت او موجوده في الليفر. طب ايه الفايده اللي هتعود على المجتمع من علاج العيانين بتوع البلهارسيا؟ cessation of egg excretion with block of egg meridium is still part of the life cycle of the parasite and hence reduction of the disease transmission in the community. يبقى ده بيقلل البيردن اوف انفكشن. What about the ideal؟ احنا دخلنا في different grades او different era of anti-schistosomal لحد ما وصلنا للدواء المثالي. الدواء المثالي اللي يبقى high cure rate, has lethal effect, easily administered, short course, free from or has minimal side effect. وعشان كده ربنا سبحانه وتعالى رزقنا بثلاث ادويه مهمين جدا جدا، اثنين في الباست واحد في البريزنت، حاجه اسمها متروفونيت وحاجه اسمها اكزامينوكوين وحاجه اسمها برازيكوانتال. وحاليا دلوقتي المتروفونيت دلوقتي ما بيستخدمش لان ده كان بيشتغل في الشيستوسومايسيس، وقدام حضراتكم الميكانيزم اوف اكشن. والاوكزامينوكوين كان بيشتغل في الجاسترو انتستينال او انتستينال شيستوسومايسيس وما بيستخدمش دلوقتي خلاص. اتفضل عندنا الحصان الرابح اللي هو البرازيكوانتال اللي جاب ريزلت كويسه جدا جدا. يبقى this is an isoquinoline compound with the high therapeutic activity against all species of schistosomiasis. ويستخدم في المنسون والهيماتوبيوم. very safe non toxic agent. بندي الدوز بتاعتي 40 ملي جرام بر كيلو جرام بودي ويت. في التشيلدرن والجابونيكام بندي ويل بي 60 ملي جرام. الكيور ريت بتاعه 80%. وبيعمل ايه بقى البرازيكوانتال؟ بريديوس اولموست انستينيوس كونتراكشن، يعني بيحصل كونتراكشنز في الماسلز اوف ذا بارازايت، وبي followed by spastic paralysis of the worm and rapid vacuolization of the tegament. بيخلي الدوده كما لو كانت عامله زي خيال المآتة كده. In vivo, these changes will lead to the loss of attachment of the worm to the endothelium of the vessel's wall and subsequent migration to the stream of the blood to the liver, where they be attacked by the phagocytes, granulocytes, and cell-mediated immune cells. Fibroplastic capsulation then occur and total disintegration of schistosoma follow, so the immunological defense mechanism of the host constitute the essential element of therapeutic activity of the paraziquantal. يبقى بيشتغل حاجه على الورم ذات نفسها وحاجه على الاميون سيستم، وعشان كده هذا الدواء ناجح وبيجيب فيري هاي كيور ريت. الدراج سيف واللي فري اوف توكسيك افكت وليه ماينور. برازيكوانتال افيلابل عندنا في الماركت تابلت 500 مللي جرام اللي بيتباع على شيء عباره عن التريد نيم بتاعه بيلتريسيد او تستوسيد او سيستوسيد. في ادويه لها دور ثانيه في حاجه اسمها المير او ميرازايد، وده عباره عن عشب من الاعشاب النباتيه. والاكزاكت بليس اوف ثيرابي از نوت يت كلير اند اتس كلينيكال اكتيفيتي از كونتروفيرسال. دوز 10 مللي جرام اوف ذيس 3 consecutive days have been proposed. في دواء ثاني المير اكستراكت والارتيميزامين، ده بيستخدم كانتي مالاريال. ارتيميزانين derivatives which are potent anti-malarial demonstrate activity against Schistosoma japonica. الارتيميزانين derivatives which are potent anti-malarial demonstrate activity against Schistosoma japonica هنا. هل ندي العيان علاج ونسيبوه؟ لا، لازم نعمل له فولو اب. مهم جدا جدا جدا. الفولو اب بتاعنا امتى يا دكتور؟ بعد 3 ل 6 شهور provided that is no exposure risk. Schistosomal antibodies لو العيان develop antibody it will remain positive for years despite successful treatment. الايزينوفيليا احيانا تيجي تعمل سي بي سي تلاقي الايزينوفيلز عاليه يس لان في ايفاكيوليشن وفي ورم موجوده جوه لسه وبتموت فلازم تعمل ستيميليشن فور ذا immune system ويحصل ايزينوفيليا. في الانديميك اريا complete cure is often impractical due to the high rate of reinfection and there is belief that is the persistence of the few living worms maintain what we call the concomitant immunity. ودي كلمه اخيره هقولها يعني already we have an immunity for the new coming infection but not complete what we call the concomitant immunity. البريفنشن بيعتمد على الماث كيموثيرابي والتارجتد بوبوليشن واحيانا بنعمل سنيل كنترول وعندنا امل كبير جدا 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 في اللي احنا نقلل الريسك اوف انفكشن عن طريق الفاكسينيشن ولكن لقينا ان الموضوع بتاع العلاج اسهل بكتير جدا جدا من الفاكسين. اتمنى ان يكونوا الحمد لله يعني وفقنا في وصول المحاضره لحضراتكم والسورس موجود معاكم ولو فيها حاجه احنا موجودين في قسم التروبيكال ميديسن for any explanation or any questions. Thank you very much for listening and thank you for the our department and our faculty for facilitating this online teaching. Thank you, Dr. Abdel Fattah.